Next, I'd like to introduce Elizabeth Edgerton. Dr. Edgerton is with us as the Director of the Division of Child and Adolescent and Family Health at the Maternal Child Health Bureau. She's worked tirelessly in the field of EMSC, injury prevention and clinical preventive services throughout her career. And she's here to share with us a lot of what they've learned in the past few years about pediatric emergency readiness, where we have gaps and where we can do better. So, Dr. Edgerton.
Okay. Well, again, thank you so much for the privilege of presenting today to all of you. And as you said, it's nice to follow Ben's presentation because hopefully I'll be giving you a model about capacity building and trying to match need with resources and, again, that health system strengthening. So today I'll be presenting on the pediatric readiness, the best practice for traumatic care for at least you to consider. First, I wanted to take a moment to share with you about the Emergency Medical Services for Children program. It's based at the Health Resources and Service Administration, which is part of HHS. We are the only federal entity that supports emergency care for children, both in the pre-hospital and hospital and return to the community. Our program is divided into different areas of focus, as you can see here on the slide. We provide 58 state partnership grants to states and territories to provide infrastructure. And again, our state partnership grantees really are ensuring that there is a champion in the state that focuses both, again, on the pre-hospital and hospital care of children. We work on regionalization of care to address that systems integration that was addressed in our previous presentation. We're looking at quality improvement, which is what the focus of this topic today will be. We also support what's known as the Pediatric Emergency Care Applied Research Network, and that is a multi-site clinical research network that really tests clinical interventions to develop the evidence so that we can give the best treatment. And then we also have an investment in what we call our targeted issue grants. And these are kind of our innovation laboratory grants that help us realize where to move the field in the future. But I felt it was important that you understood kind of the complexity of our program and how we move forward on this initiative. As we've heard of what occurs in other countries, we still have many challenges here in the United States. And on the left of the slide, you see our EMS or pre-hospital setting. And we know about only 10% of calls that a pre-hospital provider takes deal with children. And only about 10% of those are critically ill children. And that could be, again, the example of a child who falls from the window, non-responsive, scalp hematoma. And how do we prepare that pre-hospital provider to not only assess, but then transport that child to the appropriate place? And as we move to the emergency department, we still see, again, this mismatch of potential pediatric capability and resources where only about 5% of children are treated in pediatric emergency departments. And again, we have a situation with our child who's fallen out of the window, who might be taken to a critical access hospital. And a critical access hospital on the whole sees less than 5 pediatric patients a day. So that ability to be ready for care of the child can be challenging. And again, as we move to the trauma centers, a field that you all know much more about than I do, about only 10% of children are seen in pediatric facilities. So again, we know that level 1 or level 2 trauma center may be more than an hour away from a patient. So the focus of our Pediatric Readiness Project is really changing from the person providing the care to a system that delivers a care so that anyone who sees a child is ready to care for them. So this project was based on the 2009 joint policy guidelines called Care of the Child in the Emergency Department. And it was a joint policy statement put together by the American College of Emergency Physicians, the Emergency Nurses Association, the American Academy of Pediatrics, and the EMS for Children's program. And it really focuses on looking on specific domains that should be in place in any emergency department to care for children. Obviously, the administration and coordination of care, those that provide the care, the physicians and the nurses, having a quality improvement system set up to review the care you provide, ensuring patient safety, establish policies, procedures, and protocols, support systems, and then obviously the equipment needed to care for children. So based on this, let me go back there. Based on this guidelines, we developed our National Pediatric Readiness Project and a steering committee that looked at these elements to launch a national quality improvement initiative to ensure that every emergency department in the United States was prepared to care for children. And again, this comes in a context where we've seen natural disasters, geography, resources that really limit assuring that a child might be able to be transferred to a higher level of care, and we really need to be able to provide the best care of where a child enters our healthcare system. So the process in developing this National Quality Improvement Initiative started with developing a group of our champions and stakeholders there on the left that you can see. And a group got together using a Delphi process and reviewed the guidelines for the care of children in the emergency department and gave a clinical weighting to each of those sections, which you can see in the middle part of the screen. And we weighted those sections based on what was perceived as the clinical importance of having those elements present in one's emergency department for a total score of 100. And again, this becomes called our weighted pediatric readiness score. And then we developed incentives to engage emergency departments to participate in this quality improvement initiative. And those included, one, getting a pediatric readiness score in the light of being a benchmark as a baseline of where they are and where they could improve. They were given a gap analysis in which each emergency department was told areas that they were successful in, or in one of the domains, if they were lacking, next steps or evidence-based approaches they could do to improve that component of their emergency department. They were provided access to clinical tools and access to a web-based toolkit that provided templates of policies, procedures, care plans, things of that such. And what you see up here on the top of those numbers, when they did complete the pediatric readiness assessment, they could compare their hospital to like-sized hospitals, as well as hospitals within their state and the nation. So it really allowed them to look at themselves compared to other facilities of their size, and then to see how they are in relation to their state or the nation. This was launched in 2013 to over 5,000 emergency departments, and we had an 82% response rate. So over 4,100 emergency departments responded to this initiative. So again, we had taken a coalition approach, again with many champions, but I think it also is a test to the field's need of wanting to do the best thing and to really looking for solutions to provide pediatric care. So what I'm going to present to you now is the findings from our national assessment, which were published earlier this year in JAMA Pediatrics. What you see on the top here is the pediatric volume. So we broke things out because we know volume does seem to have an impact on one's readiness. So we have all hospitals. We have low volume hospitals. And again, these would classically be your critical access hospital or a facility that sees less than 5 patients a day. And I want to take a moment just to operationalize that. So that less than 5 pediatric patients a day could be an infant, it could be an 8-year-old, it could be a 14-year-old. So again, one's skill set and competency to cover that large age spectrum can be challenging. We have medium hospitals, medium high, and high. And again, on the high end, those do capture your children's hospitals, your pediatric trauma centers, but they also capture a large proportion of your community hospitals. So this is any facility that has more than 10,000 pediatric visits annually or greater than 25 children a day. What I want you to also notice is of the emergency departments responding to this assessment, almost 40% represent low volume facilities, and only 14% represent high volume facilities. And again, just so that you know where children are seeking care versus where we may concentrate our skill set and workforce and resources may be a mismatch to the field. The next line, you see the weighted pediatric readiness score. And for all hospitals, we see that the weighted pediatric readiness score is 68.9. This assessment was last done in 2003, so we've shown great improvement of almost 15 points. And we see that the pediatric readiness score for low volume is 61. And as we increase the volume, we get up to 89.8 for a pediatric readiness score. So I think intuitively this makes sense. The more patients you see, the more procedures you do, the more ready you are. But this initiative really wanted to look at how can we look at things that we can change. We can't change the volume that a facility sees, but are there other elements that are predictive of a facility's readiness? So this slide looks at what we call the impact of our pediatric emergency care coordinator. And this is a person who is assigned within that emergency department to really be the champion around pediatric care. That would include training, quality improvement, assuring that equipment's present. And we asked both whether there was a nurse pediatric emergency care coordinator present or a physician pediatric emergency care coordinator or both. And this recommendation came out of the 2006 IOM recommendations of elements that should be present in an emergency department. So as we go across left to right, we see that having a nurse increases your pediatric readiness score as well as a physician, and then that's even increased more if both are present. And again, if we look at the top right-hand corner of a low-volume facility that has both a pediatric emergency care nurse as well as a physician, their pediatric readiness score is 70. And that almost brings them to the same point of having a pediatric emergency care coordinator of a higher volume facility. So again, having that coordinator can augment not having the volume present in your facility. We wanted to then look at the role of accountability in pediatric readiness. Again, this assessment really looked at volunteer completion of this online assessment. But again, what happens when there's some form of verification? And again, looking to the American College of Surgeons verification process. So in California, we looked at the readiness data there, and we had 4 different designations levels of accountability. What was called Pediatric Verified, in which an on-site visit was conducted, and there was some method to hold that facility accountable. So primarily in Los Angeles County, that could be, again, diversion of 911 calls. So again, you had to be pediatric verified to ensure that you could receive 911 pediatric calls. There was another level called Pediatric Assessed, and that included just an on-site assessment with no means to hold the facility accountable for being deficient or having things present. We had the non-assessed, so there was no process in place. And then a look at the trauma designated process. And again, in California, their trauma designation of level 1 through 4, and then again, non-trauma. But I want to point out that the trauma designation is not inclusive of these other types of accountability, but was put forward because it's a model that we're familiar with. So if we just look at pediatric verification, in California, 300 of the 335 emergency departments completed this pediatric readiness assessment, and their mean pediatric readiness score was 69. Then if we look at the lowest form of accountability or non-pediatric assessed, we see that that pediatric readiness score is 65. And as we go up with the level of verification and accountability, we see the increase in the pediatric readiness score. So to the far right, a pediatric verified facility, of which there were only 51 out of the 300 emergency departments in California, that pediatric readiness score is 89. And again, this was recently published in the Annals of Emergency Medicine. Now, if we look at the designated trauma centers to see where that overlay is, we see that either level 1 or level 2 facilities had an average pediatric readiness score of 87, and they represented 31% of those pediatric verified facilities. Just that's a subset. And then when we look at level 3 and 4, we see that the pediatric readiness score is 65, and they represented 10% of that pediatric verified population. And then we had a separate group of pediatric designated level 1 or level 2, and those had a weighted pediatric readiness score of 95. So they were either in a category of being a pediatric verified facility or were linked to a children's hospital. So again, the point is that there was some process of accountability or pediatric champion there to contribute to their readiness score. Then if we look at some of the systems or elements that was put forward in a joint policy recommendation of having an emergency department ready to care for children, we see that the higher level trauma centers had more pediatric QI processes in place, 64% compared to 21 of the lower level. Again, had the presence of a pediatric disaster plan, had policies that are essential, again, with the transfer of a patient, whether that be an interfacility transfer guideline or agreement. And again, had the presence of a physician pediatric emergency care coordinator or a nurse pediatric emergency care coordinator. So if we're just looking at the trauma facilities and trauma verification and its influence on the pediatric readiness score, we see that those facilities that are not designated as trauma centers had a readiness score of 68, while those that were a level 1 or a level 2 had a readiness score of 87. And again, those that were a level 3 or 4 had a pediatric readiness score of 65. And finally, that subset that were level 1, level 2 pediatric designated had a readiness score of 95. But the one piece that we're still investigating is when we control for pediatric verification, annual patient volume, and trauma, when we control for the verification status and the patient volume, the trauma center designation was not predictive of a greater readiness score. Then if we look again at the form of verification status, in that first column we have the 51 facilities that were verified, 31 that were assessed, and then the remaining that were non-assessed. We see the main areas where we see that difference. One is in administration, and that's where our pediatric emergency care coordinator element lives, whether that's a nurse or a physician. And then we also see the impact in quality improvement processes. And again, really reviewing the care you're providing and making interventions. And those were the two domains where we saw the greatest impact of this accountability. And another way to look at it, if we look at all of the emergency departments that had a pediatric emergency care coordinator, if that was present, their pediatric readiness score was 85 versus those that did not have that element was 58. And if we looked at those of a QI process in place, their readiness score was high as 88 compared to 62 those without. And then if we look at that subset of the PEDS verified emergency departments, so again, that they had an on-site visit and some means to hold that facility accountable, 96% had a pediatric emergency care coordinator and 92% had a quality improvement process in place. So again, the benefits of a pediatric verification program, as you know, again, from the trauma model, it establishes a minimal standard for all pediatric emergency care facilities. And they really serve as your entry point into the trauma system, as you well know. And again, address the issue. Remember that almost 40% of those emergency departments were low volume facilities and represent our critical access hospitals. It's a way to address regional gaps in resources and is a model for inclusive model for pediatric trauma care. As we move forward with our National Pediatric Readiness Project, it's really an inclusive model and not a hierarchical one, so that everyone has a role and a participation in the care of the child no matter where they enter in that healthcare system. And again, the potential for improved clinical outcomes and improved patient safety, as we often talk about, the right care at the right place at the right time. And again, in those situations where we have disaster planning, if we're not having the infrastructure for everyday care, then we really don't have the infrastructure for disaster surging. So again, we're in the process of the next stage of this National Quality Improvement Initiative, in which we've reopened this assessment portal. And so states are allowed to go in, each emergency department can go in and recomplete their assessment to see what interventions they've put in place and how that's impacted their readiness score. It also allows states or regions within a state to implement quality improvement projects and kind of dashboard their success. Again, if you're interested in participating or getting more information, each of your EMSC state partnership managers within your state is a great source. Also, we worked with emergency department nurse managers in all of these emergency departments, as they are often the champion for the care provided. And again, we really want to emphasize that this is a joint effort in collaborating with our partners, which include the Pediatric Trauma Society and the American College of Surgeons, to really improve the readiness across our nation. I wanted to share these resources with you, in which you can find more information. There's the pediatricreadiness.org, which has a dashboard and freely accessible tools to improve one's readiness score, or procedures and policies or best practices used by other facilities. The pedsready.org is our assessment site. Our EMSC National Resource Center, again, is where you can find your EMSC State Partnership Manager information. And then nedarc.org is where our data technical assistance lives. So again, if you have any questions or further concerns, you can reach me here at this address. And thank you again for your time.
All right, thank you, Beth. That was really wonderful. I think it kind of built on what Ben had started, and the needs are not just global; they're also still needs in the United States, despite what we've accomplished so far. You talked about the PEDS emergency care coordinator and the QI process as being keys to what has led to a lot of the improvement that you've seen over time. One question is, does that have to be at that center, or can one of these expert centers help a non-expert center to be better without physically being there?
No, I think that's an important role that we need to tap into. And so whether our pediatric centers or trauma centers really serve as almost a regional pediatric emergency care coordinator is definitely a model to consider. But we know that we have someone who's kind of the champion, who's raising those issues and ensuring that these systems are in place is really essential for that pediatric readiness.
Great. I'll just open it up to the panel here for other thoughts and questions.
Yeah, Beth, that was great. I enjoyed the presentation. 2 questions for you. First of all, I'd like to hear what your definition of PEDS actually, what the age is for that, just because you had looked at the numbers, which is always a hot topic. And second of all, I'd like to ask you, pediatric verified, how do you actually do that? Is that the state requirement? Is that something that is done at that level? And how do you keep it consistent across the states?
Good question. So for the California data, they have what's called the Emergency Department Approved for Pediatrics, and the highest concentration of those emergency departments are within Los Angeles County. So the actual EMSC program and the EMS agency liaisons, they call them LEMSAs in California, would actually go to verify, and then they would work with the EMS system again to come up with that process. We currently have 14 states that have some form of recognition verification, and they all use different models. So your point is very well taken, and so we're looking to the states to understand the dynamics and components and what makes sense to them. But I think the important piece is that assessment is that first step, but some level of accountability really ensures the consistency there. Regarding your question of pediatric, that is the Pandora's box, and we did ask each of the emergency departments to define what that was, and the range was anywhere from 12 to 25. We also did look into where those patients were housed. Many of them are placed in general wards or even adult ICU. So I think we have a lot of room to go. But I think we also need to be realistic of what resources are available when a child arrives, and especially in a disaster situation, that we look at as an opportunity versus not the optimal situation, but how do we really support those systems if that's the structure that care is provided.
All right. Any other questions from the panel, or do you have any?
I'm curious. You had shown that the verification process seems to add something even to verified trauma centers. What do you think is in that makes it better? What's kind of the secret sauce of the verification that maybe we and everyone who's watching can learn or take from it even today and start making better?
What I kind of think it does is it forces the conversation. It forces that collaboration and kind of closed loop communication. Just as you know, when the American College comes for a site visit, right? Suddenly there's a hubbub in the hospital and all the departments are talking and everybody's reviewing what they're doing. And so suddenly you've kind of given a stimulus for that collaboration and alignment of resources and policies and needs. And I think that's the element the accountability provides. Obviously, when it's transports or the types of patients you're getting, there's a monetary incentive, but I think we know from many studies that it's more the value of what you're doing and the purpose that has the bigger impact than just the financial. So I think that's what it's a stimulus to, is that forced kind of discussion and integration.
Great. Thanks, Beth. That was great, and keeps us on this track of figuring out how we can get better. I'll leave you with the same question I left Ben to think about to come back at the end of this session: is how can technology like this or other ways help those hospitals that we know a lot of kids don't have access to the pediatric trauma center? How can technology like this help those centers? So thanks again.